In this episode, we're going to discuss why stretching can be a waste of time, why it's not genetic, and why you can't run to get in shape.
Welcome to the Chain Effect Podcast, where a physical therapist and a dietitian married with 2 kids juggle the struggle of running a business, raising a family, and prioritizing our own health, all while trying to have as much fun as possible.
We're your hosts, Taylor Pope, Doctor of Physical Therapy, and
Caroline Pope, registered dietitian.
Together we own and operate a health facility bringing together physical therapists, dietitians, personal trainers, and active recovery services to create what we call the Chain Effect. Today we're going to talk about some physical therapy opportunities for re-education. I know that sounds like that might be boring, but
Otherwise known as misconceptions.
Misconceptions. And basically what people come into physical therapy thinking it's going to be versus what it really is. And these are things that, we might as well make a podcast out of it because I'm basically talking about it almost every day. And the first one is that it's all about the stretches. And people want, they think they're going to come in and all I'm going to do is give them some stretches and then they're going to do the stretches and then all of a sudden they're going to feel better.
I think this is so true. Like grab a towel. You're going to be doing these overhead stretches, pulling apart. You're going to do this at home, put a towel here and stretch this way.
And to be fair, when I worked at my first job as a tech before I went to physical therapy school, I worked at a clinic that did prescribe a lot of stretches and did prescribe these sort of elaborate stretching routines that in my mind now really miss the mark as far as what quality physical therapy is and how we're actually going to solve these problems. So first of all, it's not all about the stretching. In fact, if you can't touch the ground because your hamstrings are tight, that's okay. That's okay. You might need to work on a little bit of hamstring flexibility. There might be something going on, but a lot of times I tell people you need strong hamstrings. You need those hamstrings putting your pelvis in a better position so that you're able to stack your spine appropriately so that we can get you, stronger in that posterior chain and more aligned from a skeletal standpoint.
Because you can't touch your toes, right?
No. And honestly, that does, so to be fair, could I stretch more? For sure. But there's a proper time and way to do it that is most effective, and just doing a stretching routine or thinking that you're going to prescribe someone this stretching routine and then they're just going to go home and actually spend the time to do it is just, a pretty big reach. So oftentimes why someone actually feels tight or why they're in pain doesn't really have to as much to do with flexibility. Usually it has to do more with strength, activation, and motor control, which are all kind of related into that idea of stability. And so we'll have a lot of people, and the best example of this is when I have someone come in and they're having low back pain and I ask them to, because it is part of our screen, reach down and touch your toes. And I ask them to do it and they put both hands on the floor. And then I ask them, I say, have you always been pretty flexible? And they're like, oh yeah, I'm really flexible. And I've been trying to stretch. I've been trying to stretch my, my back. I've been trying to stretch my hamstrings. And the problem just isn't getting better.
Yeah. And more needs to be done. It's not just the stretching.
That's right. And so what is actually probably happening with that person is that their deeper stabilizing muscles are probably inhibited because they're not putting their body into a proper alignment and then activating those muscles under load. So I would say in a, sort of across the board, people are pretty weak. In general, most of the people that I see need a strength solution.
Yeah.
They might need a little bit of joint mobility, but most of the time they need a strength solution. And I'm not saying that there's not situations where there might be a muscle that's inhibiting joint mobility, and we do need to work on that. But a lot of the times their joint mobility is inhibited by their structural or skeletal alignment. Mm-hmm. So for instance, they're not able to lift their arm all the way over their head because their shoulders are rounded forward. They're not able to turn their head, all the way to the right or left, or look up, look down all the way because they have forward head posture. Their thoracic spine is restricted because it's stuck in a kyphotic posture as opposed to being in a more neutral or extended posture. Mm-hmm. And so, the skeleton will limit some of those in ranges of motion. But a lot of times when we work and, get some good motor control in those positions, we're able to increase that mobility pretty quickly. And so in that case, it's not usually a muscle that's inhibiting it. It's more of a positional preference.
Yeah. And to be honest, I think that idea of stretching is a deterrent for a lot of people for going to physical therapy. If they assume that's what you'll do,
yeah.
He's just going to give me some stretches and then, have me do some exercises, get on a bike, and then go home and do all these stretches. And people don't like stretching most of the time. I do.
Yeah.
Feels good. I don't do enough either, like at the end of a workout or in general, but people just don't really like stretches. They think they're boring.
Well, we both love yoga, which has a decent amount of stretching.
Yeah.
But the thing about yoga is you're also loading while you're stretching, right? So you're getting into these positions, you're stretching a muscle for maybe part of a posture, but then you're also loading and doing some strength work and moving in sort of more of like a calisthenic type way. Mm-hmm. So that can be a lot more fun and is a lot more effective. So, there is a big benefit to having a mobility practice, but just thinking that you're going to solve your low back pain by,
stretching
doing a few hamstring stretches or, doing a few easy things like that is just not the reason that it's going to work.
And do you think going to something like yoga or doing yoga videos to stretch and help the back pain makes it worse for some people?
It definitely does for some people who are already hypermobile.
Oh, okay.
So if you are someone who has a lot of flexibility and you're doing a lot of in-range stretches and things like that, you're probably moving from the places where you already have a lot of hypermobility and or a lot of extra mobility anyway. And so you could be overdoing it in those areas of your body versus where you might actually have a little bit of limitation that we need to figure out. So that's a huge misconception and something that we deal with all the time. And
so it's not all about stretches. Number one misconception. Yeah. It's not all about stretches.
It's not all about stretches. Number two is that small, isolated physical therapy exercises are going to fix your problem. So this is where, the physical therapist prescribes them some TheraBand and says, I want you to do, 20 rows or pulls with the TheraBand. And I get it. They're trying to give them something that there's no barrier. There's no barrier for at home. If I give you the band, you can't say that I don't have any exercise equipment to be able to do this because you do have a band.
Right.
But the reality is most of the time when we hone in, like let's say you come in for knee pain or you come in for shoulder pain, when we just hone in on that specific joint and examine that, we're missing so much more of what's actually contributing to that. So I always like to discuss this with my patients, and I think I've talked about it on the podcast before, but this concept of regional interdependence. And that's a, Gray Cook FMS, functional movement systems type concept where, and I'm pretty sure he's the first one to talk about it, but essentially there's each joint in the body has a primary function of either mobility or stability, and they alternate. So this is where we start talking about like the economics of movement, the cost and supply of movement. And so if we start at the toes and we're just going to go straight up the body. So we're going to go toes, midfoot, ankle, knee, hip, low back, thoracic spine, neck. We're going to go straight up the body. So if we start at the toes, and it's easy to remember because if you start at the end, fingers, toes, and upper cervical spine, it's always mobility. So you can always start at the end point and it's going to be mobility, which makes sense, right? Like if you had a flower growing out of the ground, it would have where the petals are would be able to flop around in the wind. Yeah. But then the roots would be
sturdy.
Yeah, exactly. Would be holding it stable, right? So if we start at the toes have a primary function of mobility. The midfoot, which is where our arch is, has a primary function of stability. So we need to control motion there. We move up to the ankle. The ankle has a primary function of mobility. We need to have a lot of good mobility to flex, dorsiflex, invert, evert, rotate our ankles. Then we come up to the knee. The knee, which moves a lot, but it actually only moves in 1 degree of freedom. So bends and straightens with a tiny bit of rotation in there, but and a little bit of side to side. But we primarily need that to be a stable joint. And when we have
the rest of the leg,
exactly,
the hip and the ankle.
That's right. And when we have too much motion there, that's when we run into ligamentous injuries or different types of meniscal injuries or patellofemoral pain from the kneecap not lining up in the toe in the joint correctly. Moving up from there, we have the hip joint, which is a ball and socket joint. Primary function of mobility, has a lot of motion, just like our shoulder. Coming up from there, we have the lumbopelvic junction. And this can kind of confuse people, but basically your pelvis and your low back, they need to be able to move independently, but oftentimes they're working together to create stability. And that is where we get that core stability, right?
Pelvic floor.
Exactly. And a lot of that has to do with the nature of the psoas, because the iliopsoas is actually 2 muscles, the psoas and the iliacus, and those are both your hip flexor. So your ability to just stand up straight and lift your knee straight up off the ground, basically lift your leg up off the ground, is primarily powered by that muscle. And it actually connects into your lower back. So the little wings on your vertebrae called transverse processes, it connects to the front side of those. So the anterior side of those, think about like where your stomach is. And then it moves forward down through the pelvis and connects to another muscle, that iliacus, which is in the inner rim of the pelvis and then down onto the leg. So those 2 muscles really work together for you to be able to stabilize that low back, stabilize that pelvis, and then lift your leg up off the ground. So if you're doing a sport like running or something and you're lifting your leg up off the ground constantly, but you have very poor control over that muscle, you don't have the stability necessary to be able to drive that leg up and down over and over again. And then you're going to have low back pain because it's pulling from the anchor, essentially.
It's all connected, like we always talk about.
Exactly.
All connected.
So moving up from the lumbopelvic junction, I'm almost done here, but we got the thoracic spine.
An anatomy lesson.
Exactly. Well, then we have the thoracic spine. And the thoracic spine has a primary function of mobility. And it's due really to the changing of the facet joints, which are like little ways that each vertebrae is connected. But in the thoracic spine, we allow a lot more flexion, extension, rotation in the thoracic spine. And so that has a primary function of mobility, which leads us to the cervical spine. The lower part of the cervical spine has a primary function of stability, and the upper cervical spine has a primary function of mobility. So think about like nodding, turning your head left to right, etc. That's primarily occurring from your upper cervical spine. The atlas and axis. Coming back down to the shoulders, just real brief, but the shoulders basically live on the thoracic spine. The scapulas live on the thoracic spine, so that has a primary function of stability. It's on the mobile thoracic spine. And then coming out from there is our ball and socket of our shoulder, which has a primary function of mobility. Elbow, like the knee, is stability.
You can't move that around in
a
circle.
Exactly. Wrist, like the ankle, is mobility. And it's almost like at one point we walked around on all fours, right?
Yeah, because arms and legs are so similar.
Exactly. And then hand bones, stability, and fingers, mobility. Whew.
When you describe all this to patients, do they give you a blank stare?
No,
like me, because I can't keep my attention too long.
You definitely have a hard time with that. She's got what was that Chappelle show where it's like wrap it up? It's like the
wrap it up, B.
The wrap it up
like,
thing. Okay, wrap it up. A little quick. Yeah. Well, no,
very interesting.
They stick with me because they, haven't heard me talk quite as long as you have,
and they want to feel better.
Yeah,
they want to get better.
But this is basically a huge framework for how we can both self-diagnose problems and connect problems that are seemingly unrelated. Mm-hmm. So for instance, if I have a joint like the hip joint, which is supposed to be mobile, right? And it is restricted. We're having restricted motion in the hip. And I'm doing a sport like running or anything, or even if I'm just walking around and sitting all the time, if I have restricted motion in my hip, I'm going to be seeking that mobility from the adjacent joints. So that's going to be the knee, but it's also going to be that lumbopelvic junction or the low back. So I'm going to be seeking, or the SI joint, I'm going to be seeking that mobility from those areas. And so I'm going to be placing an increased mobility demand on those areas. And that's where we run into problems because now we're not using that joint effectively. So when I have someone who comes in for knee pain, I'm going to look at their ankle, I'm going to look at their foot, I'm going to look at their hip, their low back, and really try to find, what might be driving that knee pain, because often that stable knee joint is just victim to restricted mobility somewhere above and below.
Yeah. Since being with you, I feel like there's been so many times where friends or family have mentioned, or even patients have mentioned, like, oh, my hips are hurting, my lower back is hurting, my knees are hurting. I'm like, well, it could be connected. It could be your ankle. It could be you should go see a physical therapist because it could be not that at all. It could be from something else.
Well, you've definitely been in conversations where someone will walk up to me and just says, "What's wrong with my knee?"
Yeah, my knee hurts.
What's wrong with my knee? It's like, or I even
could be your back.
I have teammates who are like, yeah, I'm having this knee pain. Like, what do you think I should do? Do you think I should strengthen it? Do you think I should do this, and this? I'm like, well, without really, taking a look at the whole picture, I really can't give you good advice.
Same. Whenever we're out and people find out I'm a dietitian and he's a physical therapist and they ask us point blank random questions like, fix me.
Yeah.
I always give the answer they don't want to hear. Like, it's not black or white. I'd really have to see what exactly is going on subjectively in your life.
Yeah.
What's your diet? What's your health history?
And it seems like a cop out because they're like, well, why can't you just fix me? Are you just trying to get me in for a session? And the reality is no, we actually need to, not to mention your knee hurts. There are special tests that we can sort of bias some of the ligaments and tissues, the meniscus, to see if that is actually what's driving your pain. But that might be the structural problem that is influencing your knee pain, but it's likely being driven from a mechanical source. Mm-hmm. And that really leads us to, the next sort of idea that I have to talk to people all the time about. And that is, it's just genetic, or that's just the way my body is, or
this is what patients are saying.
Yeah. I've always walked that way.
Oh yeah.
Or that's just the way my skeleton is.
Like slew-footed, walking.
Slew? Is that? Oh, toes. Is that slew? What is that?
I think so. I think that's called slew-footed.
I always thought it was like duck walk, right?
Yeah, I used to do that way more as a dancer.
Oh my gosh. Yeah.
I've gotten better.
You still, when we walk around the block, it's like I can hear you coming from a mile away. It's like I'm listening to myself walk and just listening to you walk. It's like clonk, clonk, clonk.
Yeah, all around the house outside. So number 3, people might say it's genetic. It's all the way I've always been. It's the way my body is designed.
Right. And that there are differences in shape and size of different bodies. And different bodies, there's this whole concept of like your body fitting into a certain type, like one that's meant for like more endurance running and one that's meant for more lifting and doing that type of work. And that is certainly true. But at the end of the day, the machine itself is pretty similar. And it works pretty much the same way for most people. And so when we're talking about that, the exercises, the treatment philosophy, it usually is going to be pretty similar. We get someone, even if they have a structural problem, even if they're coming in with some part of their tissue that's been overused, that's had a tendinitis or has been loaded improperly or is acutely injured because of something crazy happening to them. A lot of times the treatment plan is going to be the same. We're going to start working on functional movement patterns to get them moving the way that their body was designed to move and loading the way it was designed to load. Mm-hmm. And honestly, most people, and it's so common in the United States where we, primarily sit from age, our poor first grader right now is just, sitting all day, wiggling all day at school,
7.5 hours.
And we're just asked to
wiggling all day,
just
pretty
much.
Just
wiggling all day. His shoulders just up and down, and he's just getting it out. He's like, Daddy, my skin just itches.
So much energy.
So much energy.
One foot's on the table, one foot's on the chair when he's trying to sit.
Poor him, poor teachers, poor everybody in that situation. It's just not meant for him. But, we sit there for, so many years in a row consecutively, and that posture and then combine that with inactivity and lack of playing and all the other things. But, we sit there and we're in this basically C shape, and that leads to 2 chronic postural problems. And this was a concept. This is called crossed syndrome. But this is a postural problem that was first coined by Dr. Vladimir Janda. He was a Czech physician and researcher. And he was the first one to really bring this concept to us of upper and lower crossed syndrome. And I think we've talked about this too on the podcast. And I know it always sounds like a death sentence, but it's actually just a postural problem where you have crossed patterns of tightness and weakness in the body. And so usually we talk about it with upper quarter and then as it relates to the pelvis. And so if we think about the upper quarter, you're looking at someone who has upper cross syndrome. They usually have like a forward head. Their shoulders are rounded forward. They have
much
that
more common these days.
That curved thoracic spine, right? Where they're sort of hunched forward. And what's going on there is that they have a crossed pattern of tightness and weakness. So they're tight in their pecs. They're tight in it. And then if you draw a straight line back up to their neck, they're tight in their paraspinal. So if you touch the sort of base of your skull where it connects to your neck and you have a desk job, that area is probably pretty tender. If you have ever had someone work on your upper traps, which is basically the muscle that connects your head to your shoulders, that area is pretty tender. Levator scap. Those muscles are all tight from us being in that shoulders elevated position relative to our normal posture. And the pecs are tight because our shoulders are rounded forward and sort of pinching together. So that creates weakness. And a lot of times we call that positional or stretch weakness in the mid back and the deep neck flexors. And so what happens is because those muscles in the mid back are being stretched around the curve, and because those muscles in the deep neck flexors in the neck are being stretched forward by the neck, we're having weakness there. And so these postural syndromes basically become this feed forward cycle that without intervention is just going to continue to lead to more hunched over, more forward head, more rounded shoulders. All of a sudden, now you're really dealing with some hard-coded postural and skeletal alignment stuff where soft tissue is really playing a role. Like it's going to take a lot of mobility work to fix that.
And I feel like a lot of people don't even notice it on themselves unless they, because you're not like, often you're not looking at yourself in the mirror from the side. And if you do, you perk up. And and so if you have someone looking at you, or if you can help prevent this early on, we should.
Yeah, absolutely. And, that leads us to that lower cross syndrome. And in reality, just like we've talked about in nutrition, the fix for these is the same. You know, it's you fix both of these things by doing posterior chain strengthening exercises and having more activation and more strength and lifting heavy. That's the sort of fix for these. But if we're talking about that lower cross syndrome, now we're talking about the pelvis really being tipped forward. So you see that person that, has the belly that's sort of hanging forward, and they don't have to have a big belly to have this. They can just really have, basically their butt sticking out, lifted up, a little extra curve in their lower back.
I know it pains you when you see this. People walking around just in the wrong posture, like with this pelvis.
And this is also like the Instagram posture.
Oh, yeah.
Right? Which you're
for
seeing.
Posing
for posing, right?
Yeah.
Because it makes your butt look big and perky, right?
Right.
But,
people, especially younger women.
I think that's how you're supposed to stand.
And teenagers and college age girls, especially, you're always commenting like, oh gosh.
Yeah.
Like she's not in the right position, but it's like, but it looks better, so they get in the habit of standing like that, which is really bad.
And then, basically what's happening then is you have, again, that cross pattern. So you have a lot of tightness in your low back muscles. The muscles all around your spine are just in that shortened position because your pelvis is tipped up. You're having tightness in your quads because the front of your pelvis is now closer to your knee because that pelvis is now tipped forward. And then you're having a ton of weakness in your abs and your glutes and hamstrings.
This is really important and happens a lot during pregnancy and postpartum as well.
Huge.
By the way, you really want to focus on that posture postpartum.
And to some extent it's understandable, right? For especially like during pregnancy, you are having a giant player in the correct holding of that posture stretched out, which is the transverse abdominis. Right. And then your body is creating elastin, which is the hormone that basically allows your pelvis to open up and pass the baby through. But that's a systemic hormone. So it's going to all your joints. And I can't tell you like how,
that's why pregnant women are hypermobile.
Exactly. And like you were just walking down the sidewalk and like busted your ankle, right?
My knee.
But when we were at Lake Johnson, you just like busted your ankle and like twisted your ankle and fell down.
And I scraped my knee really bad when I was like 36 weeks pregnant.
Right.
That was scary. And
it's just that, you don't have the same proprioception because everything is a little bit more lax. And so you don't have that motor control piece. But, we talk about the importance of getting that stacked pelvis because that is basically the correction for lower cross syndrome. And so we're going to engage the abs. We're going to get a little more flexibility, maybe on a foam roller for the quads. And then we're going to strengthen and engage the hamstrings and glutes to put that pelvis into a better position. And when we do that, now we've reestablished a better base. And the rest of the spine, just due to how we hold ourselves, is going to start to have the influence on how to correct itself. Then we combine that with resistance training, strengthening exercises, deadlifts, posterior chain exercises, rows, things that are compound movements, pull-ups, things that are going to help strengthen the back, strengthen the hamstrings and glutes, and then we can have the passive tension in the back of our body to resist all of the bending forces that we have to do from sitting all day.
Yeah, and by the way, we have that Rise Against the Machine is the podcast where we go into this more, our sedentary sitting life and all the things that we can do to improve our health if you're sitting most of the time.
So, a lot of times, we'll have patients come in and their first question is, am I going to need surgery? And, there are situations where there's a structural problem. There's, a ligament is torn. You can have a tendon tear. Your meniscus can be so shredded that, it's really bothering you. You can have a disc that's, bulging so much that like you can't walk, you can't do anything. There are situations. Spinal stenosis is another one of those where like the channel for which the spinal cord just starts to get more and more narrow. Now, none of these or I should say all of these can be improved with physical therapy. But sometimes there are situations where the client is going to need surgery. But most of the time, the structural problem, again, is caused by an upstream or downstream mechanical issue. Mm-hmm. And so the patient has never addressed any of those mechanisms. And so they're constantly just loading that tissue the same way all the time, and it doesn't get better.
Well, I would imagine for someone who may need surgery, ultimately, you can do a lot to prepare to have a better outcome with this stuff, right? And the relationship of all the muscles.
Of course. And if let's say you fix the structural problem, let's say you go into surgery, but you haven't addressed any of these upstream, downstream mechanical problems, you're going to be loading that same tissue the same way. So you have to get in there. You have to start working on that stuff so that, even if heaven forbid you do need surgery, that when you come out of it, you're loading that stuff in a different way. And so one of my favorite ways to kind of incorporate some of this concept of mobility and with strengthening is to incorporate it in your supersets. So let's say, a superset is a set of different exercises that we tend to do where you can move through the exercises pretty quickly. And like while you're doing like a more leg dominant or hip dominant exercise, you're going to do that. And then you're going to move over to a more upper body dominant exercise. And then you can do some core, or in this case,
so you don't fatigue as much.
Exactly. But in this case, you could do a mobility exercise. And you could do a mobility exercise that is influencing or helping or I guess I should say reinforcing the movement that you're doing. So let's use the example of like an overhead shoulder press. So you could be doing a shoulder press, and then you could also work on your thoracic spine mobility. So you're able to get into a better shoulder position for that shoulder press and just kind of cycle through those. And the benefit of that is that when you work on mobility in this way, you're then loading that tissue in that new position. So you've gained a little bit better position.
And muscle memory.
That's right.
And build your muscle memory.
That's right. And motor control, essentially, right? You're like getting it into a better position, and you're strengthening that new position. That is so key. So the fourth and final misconception is that
what is it?
I can do cardio to get in shape. And then when I have an athlete, they think that they can just get better at their sport just by playing their sport more. So for the first one,
I'm guessing it's strengthening.
You're right. For the first
Not just cardio or running or
exactly.
playing the sport.
Repetitive exercises like biking, running, rowing, swimming are great, but they need to be part of a bigger program. Because when they're just done in isolation, and I think back to like how many people I saw during COVID who had gotten a Peloton, and then that's all they did was ride the bike. And it was like, I mean, there are some moments in time that are just better for physical therapists than others. The Peloton craze was a great time for physical therapists.
What were you seeing?
CrossFit was a great time for physical therapists when it first started. But basically, we were seeing a lot of low back pain, a lot of neck pain, because people are in that C-shaped, basically sitting posture as their primary exercise. They're strengthening the crap out of their quads. They're pulling their pelvis into that forward position.
But not the posterior chain.
Exactly. They're doing no posterior chain exercises. So their glutes are weak, their hamstrings are weak, and they're just having tons of low back pain, tons of neck, shoulder pain.
Yeah, and if you think about, we've talked about this before, but those dysfunctional postures or things in a lot of sports that are one-sided, like swinging a baseball bat, tennis.
Yes.
I'm just thinking like, you can't just keep doing that over and over and over and over and expect to get better. I mean, it's very one-sided.
Tennis.
Or rotational.
These tennis players these days, are crazy. I have a few tennis players, and they are playing tennis like 6 or 7 days a week. Oof. For hours. They're doing, and sometimes they're doing, when they're on break, they're doing like 2-a-days.
Oh my gosh.
3 hours in the morning,
strength training.
3 hours. And they do some strength training, but it's not as big of a component, and they're not doing like progressive overload, which is a pretty necessary component. Like we do need to be lifting more and more, so we're challenging not just the muscles' ability to contract, but also that central nervous system, so that we could control that movement more efficiently. So that's a big thing. We definitely, those repetitive motions are important, but they're also probably they're definitely a common cause for creating those imbalances in the muscle tissue, strength imbalances, and you're spending a lot of time in a less than functional, or we can call it dysfunctional posture, and you're not really going through a full excursion of your joint range of motion. And so when we do that as our primary or our only form of exercise, you're really sort of setting yourself up to come see me, the physical therapist. And so I would, strongly encourage you to just, make strength training part of that program. You can bike 3, 4, 5 times a week, but you need to be lifting weights 2 times a week.
Yeah.
Yeah. So that is the 4 kind of big things that I deal with almost every day.
Re-educating your patients.
Re-educating our patients. And we love to do that. We understand how, it can be confusing, especially when there's so much poor quality care in physical therapy, where you go and it is just this pre-programmed thing that,
Do you remember Tally saying that about the Olympics?
Oh yeah.
I just made me think of the Olympics.
I know, but
and we were watching, our 3-year-old kept saying boring to all these little sports like we thought were cool, like fencing and table tennis and things like that. And we'd play something. Some were a little bit less exciting, but we'd flip over and we'd watch a few minutes. We'd say boring.
Well, yeah. So we definitely want to make our sessions exciting. We want to make, real improvements. And you do that by not having like a pre-packaged shoulder program, a pre-packaged knee program that you get because you have 3 patients at the same time and you have to bill your insurance a certain way. And don't get me started on all this because I'll just go on for another hour.
But basically it's all connected. Comprehensive care is what we do. And obviously your body's connected. And obviously strength training is the
Holy Grail.
Work is the common theme in many of our episodes. Yeah. So, well, thanks so much for sharing those. That was a lot of good education. And you can email Taylor@chaineffect.us if you have any questions. And thanks so much for listening.
Check you later.